is, I think, one of the most important topics you'll ever think of in intensive care or emergency rooms. It's called Surviving Sepsis Campaign Guidelines. I think somebody else was supposed to do it, but I'll do it for you guys. So, Surviving Sepsis Campaign Guidelines is one of the biggest initiatives ever conducted by a couple of organizations together. That's why historically you should know what exactly is Surviving Sepsis Campaign. Okay. Now, in the year up to 2000, the mortality of sepsis was very, very high. It used to be to the tune of 50%, 1 in 2 dying. So if you have sepsis, one of the two will die. Among two people, one will die. That was the problem with sepsis. Okay, that's very, very high mortality. But when you say 1 in 2 dying, you can imagine how difficult it becomes overall. Okay. And until then, it was all based on what I feel, what you feel, what the doctor feels, this was the concept. That I feel you should start this, I feel you should do this, I feel you should do that. That was the thinking. The thinking was not based on a protocol, a timing, a drug. Nothing was there. Okay. Can you just call Avinash?
Sir, he's on phone with Dr. Dongre. So he's coming. I don't know.
Okay. So that was what it was until 2001, you could call it. Until 2001. Okay. It was in 2001 that a lot of things changes. Any idea what happened in 2001? So you should know this because that's how you'll understand the future of what happens. Okay. Any idea what happened in 2001? Okay. So there was a very famous ED intensivist, emergency room intensivist. His name is Dr. Emmanuel Rivers. Okay, Dr. Emmanuel Rivers at that time did a very smart thing. He actually protocolized a lot of things together in one kind of protocol. And that protocol involved giving fluids first, giving an antibiotic quickly, putting a line called as a SCVO2 line, which means putting a line inside and monitoring the central oxygen saturation. Okay, then measuring the cardiac output. Not measuring the output, actually just putting the line, and then raising the cardiac output by giving dopamine and things like that. So you put 4 or 5 things together for improvement in urine output. Okay, so he gave a target. So he made a bundle saying that this has to be done within 1 hour. So he protocolized a couple of interventions which includes SCVO2 catheter, antibiotic fluid, and urine output, and improve cardiac output, as well as Paxil transfusion. So he did these 5 things together so that with the view that this will improve mortality, and it did. Actually it did. And there was a change that occurred at that time. So in 2001, when this Emmanuel Rivers came in, 3 major societies, when this study came in and it actually changed mortality. So a bundle of 4 or 5 things together, when you do it together within a time period, okay, it kind of changed mortality. So people got very excited because you're changing mortality of sepsis from 50-60% to a lower amount, isn't it? So what did they do? They actually got together. 3 big societies got together. The European Society of Intensive Care Medicine, the Society of Critical Care Medicine America, and the International Sepsis Forum. Very large societies. All these 3 large societies joined together and they decided to have a campaign to reduce sepsis by 25% by 2035. That was in 25 years. To get it down by 25%. This was their entire plan. So that is why it is called as Surviving Sepsis Campaign Guidelines. That's called as Surviving Sepsis Campaign Guidelines. Means we want to reduce sepsis mortality by 25%. This was the entire plan. And that is the reason that they actually sat together, big continents, right? American, the European Society, the International Society Forum, all of them sat together, and then they created a protocol which came out. In the first protocol that came out was 3 years after the Emmanuel Rivers study in 2004. The first protocol in 2004. So what happened in 2004 is they came out with a protocol of sepsis which was called as SSCG 2004. Okay. Which had a couple of things, of which one of the most important things that they talked about was the resuscitation at that moment. So at that moment, it was a protocol that if a patient comes into the intensive care unit or into the emergency rooms, the first thing you do is you give a huge bolus of fluids, maintain the CVP to go up, look at the SCVO2. If the SCVO2 is less than 75%, give Paxil. If not, give dobutamine to get the SCVO2 up and maintain a urine output of more than 1 ml, 0.5 ml per kilogram per hour. So there were many things that they did. So they had to put a central line. They had to give fluids. They had to ensure that the SCVO2, that is the saturation of central venous pressure here, goes up by 75, goes up to more than 75%. Give the blood, give the dobutamine, okay, and ensure the urine output comes up. So this happened, okay, and all of us, including the whole United States, including the whole European Union, we followed this protocol by putting SCVO, including us. We all did this for a good number of years, 3-4 years we did this, where we did this. And we found it, wow, this is amazing, that this is what is, we are supposed to do. Till that time we had no idea. Till that time it was evidence based. Doctor used to say, "Chalo, give some fluid." Doctor used to say, "You start some dobutamine." But this made it into a finite protocol to an extent that even the US Mediclaim services said, unless you use this protocol, we will not give you your insurance. Clear? That was the extent, and that was the thoroughness of that particular protocol that we had to use at that time. Then in 2004, what happened after 2004 was people started questioning the protocol because huge amount of fluid, SCVO2, you put a catheter inside, it's an invasive procedure that needs to be done quickly. You getting the point? And then dobutamine, people were always worried dobutamine is causing arrhythmia. What is this happening? I mean, why should we give dobutamine? Why should we increase the cardiac output when you can just increase the mean arterial pressure? So a lot of things came into the question, and that's why three very, very famous trials. Arise, Promise, and Approach. And Arise, Promise, and Approach, I think so. Arise and Promise, I remember. These trials came in. And when these trials came in, they questioned this entire Emmanuel reverse protocol. Okay, they questioned this Emmanuel reverse protocol. So, the protocol initially had intervention and time, right? It had time bound and it was intervention bound. So, what happened as a result of Arise and Promise, these particular protocols, was that the intervention came out. The intervention came out, but the time bound remained. The intervention came out, but the time boundness remained. Okay, so what interventions came out at that time? Because the Arise Promise told us that it is not a good idea to do all of these things, to give blood, to give, look at the SCVO, to give it more to 75%. These are interventions, to give dobutamine. So all these came under scrutiny when Arise and Promise came in saying that, these are not really required. So they were very large trials. And true to the credibility of Surviving Sepsis Campaign guidelines, when such large trials comes in, they get together and then they think about this entire thing. Why are we doing this if the trials are saying different from here? Because the initial trial was Emmanuel Goal Directed Therapy, EGDT it was called, Reverse did that trial where he put all of these things together. Okay. And then the situation came in that they found these three trials coming in which actually said, it's not a great idea to do this combination. So let's cut down. So in 2008 and 2012, there were modifications of that. And the modifications of this particular trial in the emergency room said, let's not do any of these. Like putting SCVO2, giving dobutamine, giving blood, they took it out. Monitoring CVP, they took it out. They monitoring CVP, SCVO2, giving blood and dobutamine. All of these are not supposed to be done now because we found out that Arise and Promise, all of these trials said it doesn't really work. Okay. So what remained? What remained was a completely different set of interventions but the interventions came out. This is what really occurred. Clear? And then trials came out saying that we need to target certain amount of stuff and what we need to do in the first hour. Okay, so there comes the opening of something called the first hour bundle, and that's how the first hour bundle comes outside. So what remained was group of interventions, group of things that we need to do, and in a certain time. Group of interventions that we need to do in a certain time. So we started by saying do this, intervention, time, put that. Then they removed the interventions and they put only time. And they put a small group of stuff that you need to do. What do you do? So what are the four things you need to do? Any idea? If I would ask you, first thing? First thing?
Fluid bolus.
Correct. What is the fluid bolus? What is the fluid bolus? The first thing in the bundle is fluid bolus. What is the fluid bolus?
30 ml per kg in first 2 hours you have to give.
So 30 ml per kilogram in the first 2 hours. I mean, anyone wants to, what kind of fluid should this be?
Crystalloid.
Balanced crystalloid. And how quickly we should give it? If it's 2 hours, then where is your 1 hour bundle gone?
Oh, that's good. Within 10-15 minutes, first 250 ml should be.
250 ml. She said 30 ml per kilogram. Let's just put a 70 kilo individual. How much is that? 2.1 liter.
In
So
one
where
hour,
is 250 ml?
In 1 hour.
In 1 hour, how much you wanted? Just now you said 250 ml.
250 ml bolus,
Bolus.
just to see the responsiveness.
No. So let me make you understand how you do this. The when, what, why, when, how. These very important to understand how to do these things. Okay. First of all, where that number 30 ml has come from. It's just a number 30 ml. From where that number has come from. You must understand from where that number has come in the first place. Now, the 30 ml number has come from a large amount of observational data sets that happened, including the Emmanuel reverse trial. In the Emmanuel reverse trial, all those patients who went into early gold standard therapy has received 30 ml a kilogram. Are you getting the point? All of those people received the 30 ml per kilogram. So that's large data. After that, for 4 or 5 years, we followed reverse gold standard therapy till 2004. So another 4 or 5 years passed when we gave that kind of fluid. So there were a large amount of observational data sets that came out saying that fluid is really working. Okay. The third thing is when they did Arise and Promise, these trials had actually changed SCVO2, okay, which actually changed the use of SCO2. Even those trials, initially the randomization was based after a fluid challenge, which is 30 ml per kilogram. So even the latest trials that came in, Arise, Promise, also said that give that 30 ml per kilogram, and then they randomized into not doing SCVO2 and doing SCVO2 and following this and following CVP and all those things. So what do we now know? We have got great amount of data up to 2012, observational, prospective, even prior to randomized control trials, which actually say that 30 ml per kilogram works. Clear? Clear on this till now? So the approximate amount of water that we need to give, fluid we need to give, is 30 ml a kilogram. Now this is about evidence. But also you remember last time when I took a lecture, I talked about stressed volume and unstressed volume.
Yes.
Remember? So what is stressed volume and unstressed volume? I just go back to what it was. So there are two kinds of volumes in your body. One is called as the stressed volume and another is called as unstressed volume. It is your unstressed volume that is the response. The unstressed volume is the stressed volume that gives a response. Unstressed volume is not the response. Unstressed volume is what? The volume which is lying inside and it is not contributing to pressure. It is just lying inside. It is not contributing to pressure at all. It is there in your venous circulation. Large amount is lying inside, but it is not contributing to any kind of pressure. You understanding now? Yes, sir?
Yes, sir.
Whereas your stressed volume is the one that is actually contributing to pressure. That means when it contributes to pressure, what am I talking? Which pressure am I talking? It is called as mean systemic filling pressure. Mean systemic filling pressure. It is a mean systemic filling pressure that is responsible for your venous return. It is a mean systemic filling pressure that is responsible for your venous return. Clear? And that time we discussed about the fact that venous return is equal to mean systemic filling pressure minus CVP. Yeah. So mean systemic filling pressure minus the CVP is equal to your venous return. So now let me cut this short a little bit. Agar MS mean systemic filling pressure goes down, your venous return will reduce. If your CVP goes up, your venous return will reduce. So mean systemic filling pressure minus CVP is equal to venous return, and venous return is equal to your preload or your cardiac output. Clear? Clear on this? So now what is happening in sepsis? Any questions till now?
Yes.
So in what is happening in sepsis? In sepsis, what is happening? There is an intense vasodilatation. Intense vasodilatation. So in short, sepsis is also called as distributive shock. When I say distributive shock, means the blood is distributed in the same thing. Effective hypovolemia is getting formed. Effective hypovolemia. So effective hypovolemia. That's what's happening in sepsis. Effective hypovolemia. Clear on this till now?
Yes.
Clear? Now when this effective hypovolemia is happening, it is not only directing the stressed volume, it is also directing the unstressed volume. You getting the point? So if you want to give 250 ml like you said, that 250 ml will only fill your unstressed volume. It will not contribute to your stressed volume. You are getting the point? So physiologically, if you want to actually increase your venous return, I need to fill up the stressed volume, which is your mean systemic filling pressure. And that can occur only when you give very large amount of volume. You getting the point? So by 250 ml and see what's going to happen, nothing's going to happen. The point is that. Okay, it is always going to be 30 ml per kilogram initial bolus. Clear on this? So in order to improve your mean systemic filling pressure, you need 30 ml a kilogram. That's what the entire ball game is. Clear? Till now clear on this? Understood this? Now the question is which kind of fluid? Now how to give this? Before we go to which kind of fluid, how to do this then? 30 ml per kilogram, let's take an average 60 kilo. So it's 1.8 liters. It's 1.8 liters. Now is this a bundle happening here? There's a bundle happening here. Okay, now what do you do in this case? So practically what do you do bedside? So patient comes in, septic shock, you find the BP to be on the lower side. Right? What do you do? The first thing is think of fluid. First thing is think of fluid. How do you give that fluid? So over 15 minutes, the first liter has to go in.
15 minutes?
The first liter has to go in. So you have a 1 hour bundle, no?
Yes, sir.
You have a 1 hour bundle, correct? 1 hour bundle. So in the first 15 minutes, 1 liter should go inside. Okay? In the first 15 minutes, how much should go inside? 1 liter.
1 liter.
That means it cannot go without a pressure bag. It cannot go without a pressure bag. It is not impossible to give 1 liter without a pressure bag within 15 minutes. So there has to be a pressure bag. Okay? 15 minutes later, what happens? You give the next bolus. You understand? So in 30-35 minutes time, you're kind of done with your fluid challenge. Say you have a very obese individual. You're a very obese individual. Say you have a patient who is 80-90 kilos, which is usual. 90 is kind of usual. So you have 90 kilos you have, and now you multiply 90 by 30, it ends up 270, 2.7 liters. So if you have to give 2.7 liters, the same protocol follows. Give 15 minutes, 15-20 minutes, 15-20 minutes next, and the remaining finish in the next 20 minutes. Whatever remaining is there, finish in the next 20 minutes. So in 60 minutes time, you're done with your fluid challenge. And it's not called fluid challenge here, this is resuscitation. Fluid challenge is a different ball game only, where you decide, this last time we discussed what is the fluid challenge. This is fluid resuscitation. When I say fluid resuscitation, means patient is coming from outside, come to the ER may BP is on the lower side. If the BP is on the lower side, what do I do with that particular BP? In a case of sepsis, I do this. I give 30 ml per kilogram as a bolus over 15-20 minutes using a pressure bag. Repeat that in the next 15 to 20 minutes. Okay, and then the remaining you complete in the next minute, the next 20 minutes that you have. So you finished your total fluid 30 ml per kilogram in the first 1 hour. That's what is called as resuscitation. Okay, you in intensive care you may not be faced with a situation where a patient comes like that. Okay, very rarely you will have that. So you will have that, say if the patient was in the ward, patient was okay, and patient is having some fever, and now the doctor over there feels there's altered mental status. Now that patient has come down. Altered mental status is, after all, in the background of the context of sepsis, it may be actually septic shock only. Capital refill time is going down. You find your refill time. Then you think, okay, I need to resuscitate. When you think, okay, I need to resuscitate, you give 30 ml per kilogram. The usual run-of-the-mill patient will be, patient is outside, patient has some infection somewhere or the other, comes from outside with a low BP to the ER. That is the usual situation. Comes to the ER with a low BP, you check the BP and say BP low hai, chalo fluid laga do. That is wrong. If the BP is low, you have to do it in the first 1 hour. And why is that in the first 1 hour? What is the thinking? Why do you think it should be in the first 1 hour?
Early diagnosis prevents mortality. In
Okay.
1 hour bundle,
In the bundle, 1 hour bundle. But why? Why? If someone asks you why you should do it in the first 1 hour and not do it in the first 3 hours, 3-4 hours में क्यों नहीं करने का? Which normally we see ना 3-4 घंटे में कभी भी होता है यार में. क्यों? Why we should not do it?
Improves mortality. Like how much we delay, that will increase mortality.
Why?
On the first.
Why? Question is why. I understand. Why? We know it is, but that's why the bundle has come in. Why? Organ perfusion will reduce if longer time of BP. But then why not give the fluid over 4 hours? 5 hours you give it. Why in the first one? The answer is very simple. What happens is, initially when you are in septic shock, now the endothelium is not damaged. Initially the endothelium is not damaged. The hypotension is occurring. Endothelium is not as much damaged. The moment the endothelium damages, the next step is it creates holes in the endothelium, in the glycocalyx. It creates holes. Once those holes are created, that same fluid leaks out. So it will not be able to maintain your mean systemic filling pressure. At the end of the day, what is our goal? Maintaining the mean systemic filling pressure. What is known is after 3 to 4 hours, the mean systemic filling pressure is not maintained because there is leak outside the system. It no longer behaves like a system that is tight. So the benefit that you get with that fluid resuscitation is no longer there if you want to resuscitate at 3 or 4 hours. So this is in the scenario of septic shock. Clear? This is a scenario of septic shock. So the benefit that you get with the fluid bolus is not there anymore after 3-4 hours. Understood why? The endothelial glycocalyx gets spoiled. If the glycocalyx gets spoiled, then it kind of leaks out, and then whatever fluid you give will not keep the mean systemic filling pressure perfect. It will actually cause problem, and that's why you have to follow it as per protocol. Clear till now? Clear that first 1 hour why it's important? Any queries till now? Clear? Now which fluid? The question comes which fluid? So the fluid remains as a balanced crystalloid. When you say balance, what does it mean? What does it mean?
Like osmolarity same as the
Contents also. So when you say osmolarity, which is the highest contributor of osmolarity in the body? SN?
Sodium.
So correct, sodium, simple. Sodium is the highest contributor of osmolarity. Okay, now let's compare normal saline and Ringer's lactate. So which do you think is a balanced crystalloid? Why is that so?
Sodium is less.
So what happens?
It will be with osmolarity of the.
So understand this. When you give high amount of normal saline, say you give 2.5 liters and 3 liters of normal saline, what is happening is not only are you giving sodium, you are also giving chloride. Chloride is negatively charged. So when you give chloride at this high amount, it causes something called as hyperchloremic acidosis. Hyperchloremic acidosis. When chlorine goes very very high, it will contribute to the acid load and cause hyperchloremic acidosis. Clear on this? Hyperchloremic acidosis is a very dangerous thing that can occur in our body. Why? Because it causes renal vasoconstriction, okay, causing a drop in GFR and thus drop in urine output. Clear? Hypochloremic acidosis also relates to lower immunity. When you have hypochloremic acidosis, it also causes drop in immunity. Okay? So hypochloremic acidosis is responsible for causing renal vasoconstriction. So you might think that I am giving fluid and my urine output will improve. Urine output will actually drop because the GFR is going low. Okay, and urine output is dropping. So this is only in cases when you are going to resuscitate very large amounts. Okay, I'm not talking of 1 liter and 1.5 liter, 5 liters and 6 liters. So what you must understand in pathology is small amounts will not cause any problem, but very large amounts, 5 liter, 6 liter, मतलब 150 किलो का आदमी है, तो उसमें problem हो सकता है. But not in the small individual. The छोटे individual normal से देखो तो भी फर्क नहीं पड़ने वाला, because its amount is small. Okay, the amount is small. समझ में आ रहा है? Clear on this? So it's not necessary to give a balanced crystalloid. But what I can think other way around. How does Ringer's lactate actually score above when you look at physiology? Why Ringer's lactate scores above it? So hyperchloremic acidosis is not a big entity. Understand this. Hyperchloremic acidosis is not a big entity unless you are giving large volumes. So if I'm giving normal saline 5 liters, it's a problem. But if I'm giving normal saline 2 liters, it is not a problem. So hyperchloremic acidosis is not the problem here. Are you getting the point? So what is the problem? What is the benefit? If there is no problem, there may be some benefit from Ringer's lactate. What do you think is the benefit?
It has other electrolytes as like potassium.
Okay, so but we don't want potassium here.
Lactate gets converted into bicarbonate.
Correct. So that is the rationale. One of the rationale you have. Well, if your liver is working very well, there is a high possibility that you might get a little bit alkalotic. You might help it out. Why? How does it convert? What is lactate? Lactate is
anaerobic product of anaerobic.
no. Lactate is what? Is it acid? Is it base? What is it?
Yes.
It's not lactic acid. That's the entire point you must understand. It is not. It is a base actually. Lactate. It's a salt. It is not lactic acid at all. If it was lactic acid, it will cause acidosis. If it was lactic acid, it will actually contribute to metabolic acidosis. Correct? So it is not lactic acid. When you say Ringer's lactate, it's lactate, and lactate is a base. You get the point? Lactate is a
Yes.
So Ringer's lactate is not acidic. ऐसा नहीं है कि Ringer's lactate दोगे तो lactic acid बढ़ेगा. नहीं होने वाला है. That is not going to occur. And why that doesn't occur? Because it's all physiology. What happens is in your body your cells are again and again creating a carbon dioxide shadow, right? H2O gets adds with CO2 to form H2CO3, which now divides into hydrogen plus bicarbonate. Again I'll tell you. In your body, water and carbon dioxide is utilized. So H2O plus CO2 becomes H2CO3, and this H2CO3 gets converted to hydrogen ion and bicarbonate ion, H plus and HCO3. Clear on this? Clear on this? Now the moment you give this lactate inside, the lactate goes right. Lactate is taken over by lactate dehydrogenase. You remember we have done lactate dehydrogenase and then converted to pyruvate. Okay, and for that it utilizes that hydrogen ion. Got it? So it utilizes the hydrogen ion, it's taking away the hydrogen ion, and that is why bicarbonate is left out. Are you getting the point? And this will occur only since this Krebs cycle occurs in the liver. That's why if the liver is working very well, you have a possibility to create a bicarbonate. So how much bicarbonate is created? How much bicarbonate is created? It should be equivalent to the lactate. No, because it's equivalent. Number of lactate that comes outside, that same lactate is taken by hydrogen ion. So that same amount of bicarbonate remains. Are you getting the point? Again, H2O plus CO2 gives H2CO3. H2CO3 gets converted to hydrogen ion and bicarbonate ion. If these both are inside, that's why electrical neutrality is occurring in our body. Hydrogen and bicarbonate. Electrical neutrality is occurring. You gave Ringer's lactate from outside. Now lactate is getting converted to pyruvate. It goes through the Krebs cycle to become pyruvate and all those things. Correct? Now in that bargain, it takes this hydrogen ion. So once it takes the hydrogen ion, what is remaining? Bicarbonate. So amount of bicarbonate that remains will be amount of hydrogen ion consumed. Simple? So how much hydrogen is consumed depending on the amount of lactate. So the amount of lactate that you have in your Ringer's lactate is equal to the amount of bicarbonate. So 1 liter of Ringer's lactate contains 28 amount of lactate. If you read the bottle, 1 liter of Ringer's lactate will have 28 amount of lactate. So it is 28 milliequivalents of sodium bicarbonate. Clear? So there is a high possibility that this may be occurring in patients. It will occur in healthy people. I don't know whether it will occur that way. That's similar in septic and septic shock individuals. But this is the physiology behind Ringer's lactate being beneficial. Clear on this? So hyperchloremic acidosis is harmful, no doubt, but we are never going to have hyperchloremic acidosis because we are not resuscitating with 5-6 liters. But Ringer's lactate may be beneficial because of this kind of physiology that we are having. Are you getting the point? So that's why Ringer's lactate becomes an extremely important element when we are actually resuscitating our patients. You getting the point? Now why I am referring Ringer's lactate? Clear? Any doubts? Any doubts? Okay. So now you know which fluid to give, you know how quickly to give, and you actually know the actual protocol. Okay. Now, in the protocol, the first thing was giving fluids. What is the second thing?
To send cultures before starting
Antibiotics. So giving antibiotics within 1 hour. So the 1 hour bundle will be taking cultures and sending antibiotics and giving antibiotics. Okay, taking cultures and giving antibiotics. Then third,
lactate should be.
So monitor the lactate. Now, why do you want to monitor the lactate? Why exactly do you want to monitor the lactate?
It relates with perfusion, organ perfusion.
So lactates come from 3 places, not just organ perfusion. A lactate comes one from anaerobic metabolism. Anaerobic metabolism means there is no oxygen coming, that's why lactate is getting formed. The second lactate comes because of beta 2 stimulation. Beta 2 stimulation, that means today if I give adrenaline, beta 2 stimulate, lactate will go up. Adrenaline infusion, lactate is going to go up. This is going to happen. Okay, adrenaline stimulates beta 2 receptors, lactate is going to go up. Similarly, when you are in stress, your beta 2 receptors are stimulated. Since in stress your beta 2 receptors stimulated, the lactate will go up. So it not only comes from anaerobic metabolism, it also comes from beta 2. And third, it can come when extreme amount of pyruvate is formed. So very amount of lactate is coming, pyruvate is getting formed. Now lactate has to convert to pyruvate. If it is so much high amount of lactate is getting formed, then the lactate will leak out into the circulation. Clear? So there are 3 reasons why lactate gets formed, and one of the 4th reason is when the liver is not working. When the liver is not working, the lactate will go up because that is where the cycle is occurring. It is not converting to pyruvate. Okay? So that is why the lactate will go up. समझ में आ रहा है? When the liver is not working. Clear on this? Clear on this? So lactate has got many reasons. So why do we do the lactate in these cases? We do the lactate because when we are giving most of our interventions, we should see as so lactate equals badness. This you must understand. Lactate is equal to badness. अगर lactate ऊपर है, means prognosis is bad. The corollary to that is, if by any chance your lactate starts coming down after whatever you have done, within 2-3 hours, means whatever you have done has helped this patient. Are you getting the point? So if by any chance, it is not a target for resuscitation. I will not keep giving fluids, I will not keep giving vasopressors, I will not keep giving all these things to target that lactate to come down. Are you getting the point?
Yes.
But in the bargain, when I did all my stuff and I came back and I saw my lactates coming down, it basically means whatever I have done has made a difference. You understand? Has made a difference. Clear?
Yes.
Am I clear on this? So you say a lactate was, so what we have on our units of lactate, in that 1 hour bundle, all these things of giving fluids and all is when the patient is hypotensive or the lactate is more than
2.
Okay, you have to have a high lactate to whatever we want to do. Okay, so if you have high lactate, whatever we do, and when we repeat the lactate, it comes down, we can say that okay, whatever I've done well. That's why we monitor the lactate. Correct? So that is the first thing. The first thing was the fluid. Second thing was the cultures antibiotics. And then third thing is the monitoring lactates. Then fourth thing is vasopressors. Okay? I'm looking at vasopressors. So which kind of early vasopressors I will use? So now what you have understood is I want to maintain a MAP of more than 65. Where does this number of 65 come from? This number of 65 comes from large scale trials, which actually says that if you want to actually have a lower MAP of less than 65, the urine output, heart, kidney and brain suffer. We know that if the MAP is less than 65, the heart, the brain and the kidneys suffer. Clear? That means we have to maintain the MAP more than 65 at all given times. If your MAP is less than 65, things will suffer, organ damage will occur. Very clear. Okay, so can't accept MAP less than 65. However, what does the Surviving Sepsis Campaign guideline says? Individualize the MAP based on the patient. Now, why does it say that? It says keep the MAP more than 65, but also says individualize the mean arterial pressure based on the patient. Now, what does that mean? Any idea? Any idea? So what it's saying is which patients will require higher MAP? What's the logic? Which patient will higher MAP? So those patients who are hypertensive, chronically hypertensive, those patients with atherosclerosis. So chronic hypertension and atherosclerosis, you may want to individualize the MAP. It's not saying what number. It is saying individualize MAP means go up to 75 to 85 MAP. It is saying go up to 75 to 85, but it is suggesting to individualize. It's not saying do it. What is it saying? Suggesting to individualize. So if I had a 65 MAP and this patient is passing adequate urine, my lactates are coming down, my capillary refill time is getting better, I don't need to individualize in this chronic hypertensive patient. But if the patient is chronic hypertensive and I am not having, the urine output is not improving, the lactates are not coming down and capillary refill time is not getting better, I need to individualize that MAP to raise it by 75 to 85. Clear? Clear till now? That means when does this start working? Within the first 1 hour. Within the first 1 hour this starts working. So your 1 hour, first hour you started the fluid, second hour you are looking at the urine output. Urine output is not improving, lactate is not changing, capillary refill time is not changing. I start my vasopressor. Are you getting the point? I start my vasopressor. Getting the point? I immediately start my vasopressor. Now which vasopressor do I use? So and if I start my vasopressor, it doesn't go up. And urine output doesn't improve. I increase my vasopressor. I increase a second vasopressor. You getting the point? So getting the target. 1 hour later, vasopressor comes inside. 1 hour later, vasopressor comes inside with respect to urine output, capillary refill time, lactate, mentation. 4 things. Clear on this? So irrespective of where the patient is, ER, ward, ICU, periphery, you should start the noradrenaline. You should start the noradrenaline to get the MAP above 65. And if the patient is hypertensive and urine output is not coming in the second hour, raise the MAP to 75. I'm not raising as a blanket. Patient hypertensive is 75. ऐसा नहीं. Patient hypertensive and came, we did the resuscitation, MAP maintained more than 65. Urine output, lactate is not improving. I start I raise it to 75. समझ में आ रहा है? Clear on this? And this came from a study called as a sepsis spam study. Sepsis spam study, which they actually looked at 65 versus 75. When initially it was told that MAP you have to maintain more than 65, which even Emmanuel Rivers said, keep the MAP more than 65. Everyone followed more than 65, more than 65, more than 65, right? But everyone will question why 65, why not 75? If 65 is good, 75 may be better. If 65 is good, 75 may be better. That was the question that came, right? If 65 is good, 75 may be better. So what did they do at that stage? They did a trial. They looked at patients between 65 and 75 to 85. In fact, even higher, 80 to 85. They did. Okay, they did higher numbers. And what they found was the mortality did not change much, but the incidence of renal replacement therapy came down in those patients who were chronically hypertensive. Mortality did not change. इसका मतलब ये है कि मेरे को हर पेशेंट को 65 to 75 पे नहीं लाना है. But what I know is those patients who are chronic hypertensive in those group of patients, in those group जिसमें ट्रायल में हुआ था, जिसको उन्होंने मैप more than 75 रखा था, the hypertensive patients they had less incidence of renal replacement therapy. That's why the thinking is if you have chronic hypertension and the urine output is not coming and lactates are not improving and or any of the alternate medicine is not getting better, capillary filter is not getting better, you raise the MAP to 75. Simple? Is that simple? Understood this much?
Yes.
75. Now, which vasopressor inotrope you'd use? That's the next question. So, which is the one that you'd use in this case?
Noradrenaline.
And why noradrenaline? Why noradrenaline? Why not adrenaline? Why not vasopressin? Why not phenylephrine? There are three more vasopressors we know. We know adrenaline, we know dopamine, we know phenylephrine, we know why not any of these? Why? Because it all depends, it is all completely related to the physiology. It's completely related to the physiology. Now what happens with noradrenaline? Noradrenaline is a medicine that actually works on the alpha 1, it works on alpha 2, it works on beta 1, it works on beta 2. It does not work specifically on beta 1. It doesn't specifically work on beta 2. It works on alpha more than the beta. Whereas adrenaline works more on the beta, less on the alpha. Now why am I talking to you these things? Vasopressin works on a B1 receptor, completely different thing. Dopamine works only on B1. That's on the inotrope mechanism. It works only on the heart. Why am I talking to you like this? Because the physiology of septic shock is based on vasodilatation. So in that case, how much ever I improve the cardiac output doesn't make any sense. I have to constrict this. To constrict this, the only activity is alpha. To constrict this, the only activity is alpha. Clear? So if I just give an alpha agonist, it will actually cause vasoconstriction and improve the mean systemic filling pressure. Now, what is the beauty of giving noradrenaline? It converts the unstressed volume also to the stressed volume because such a powerful vasopressor it is. That now it has so much of vasoconstricting ability that the unstressed volume that we talked about, even that is mobilized into the stressed volume. So it vasoconstricts everywhere and causes the unstressed volume to become stressed volume, in effect increasing mean systemic filling pressure and improving venous return. In short, it's like a fruit challenge. You're getting the point? Are you understanding? Why not add? So then why not phenylephrine? Phenylephrine is also pure alpha. Phenylephrine is pure alpha. Why not phenylephrine? Now the problem with phenylephrine is it has absolutely no cardiac effect. So it actually causes myocardial ischemia. Okay, it will cause the heart to work against a force. It is not helping the heart in any way. So if once the increase in this occurs, vasoconstriction occurs, the heart has to really pump to move that blood across. So it can cause cardiac problems. That's why we don't use phenylephrine. Getting the point? Clear on this till now? Why not dobutamine? Because it doesn't take the pathophysiology at all. Dobutamine will only improve the cardiac output. What are we going to do with the cardiac output? We want alpha vasoconstriction. Are you getting the point? And vasopressin is a hormone. How will a hormone work like this? You can't titrate it only. It's a hormone. Do you titrate thyroid? So today morning give 25, evening give 28. ऐसा तो नहीं होता ना हमारा. That's a hormone, vasopressin. Are you getting the point? So that is not going to work in titration. Are you getting the point? So you can't use any of these other things. So at the moment you are using noradrenaline because I want to raise my MAP to more than 65, primarily because I want alpha vasoconstricting activity and I don't want too much of beta. Clear? So how much do we give noradrenaline? What would be the dose? And when do you decide, okay, no, I need a second inotrope or a second vasopressor?
When norad is more than 6, then we should.
So it's not like that. So there is a dose for this. The dose remains as 0.3 to 0.5 microgram per kilogram per minute. Okay, when you reach above 0.3 microgram per kilogram per minute, and in our case, when you put 8 in 50 of noradrenaline, it is somewhere around 4 to 6. In our case, somewhere around 4 to 6. Since it's being microgram per kilogram, it will vary between 60 and 70 kilojoules, 80 kilojoules. So you can ballpark figure is between 4 to 6. So you will keep on increasing your norad till you reach 4 to 6. maybe 5, maybe 4, smaller individual 4, larger individual 5, largest individual 6. At that time, we are reaching that particular dose at which, beyond which, it has maxed out the receptors. It has maxed out the receptors, means all the receptors are saturated. That is what we know. All the receptors are saturated. Now, increasing NORAD beyond 5 ml will cause problems with respect to digital ischemia, with respect to gut, getting ischemic, with respect to all the other problems that we have. So, are you clear?
Yes.
Am I clear?
Yes.
So, this means to say, if I start NORAD and I reach 5 ml on my 8 and 50 of NORAD, 8 milligrams and 50 cc is around 5 ml, is the dose that I mentioned. Okay. Beyond that, if I continue my NORAD, I am subjecting my patient to digital ischemia. I am subjecting my patient to gut getting ischemic. I am subjecting my patients to problems that comes because of high dose noradrenaline. Clear? So when I reach 5 ml, just tell them to stop softly. Huh? Okay. So when I reach 5 ml, clear on this? So then what do I do once I reach 5? You understood why you have to stop at 5 ml, right? You understood it very clearly. Why you start at 5 ml? Clear? Any doubts till now? Huh? So it's wrong if you keep on going 5, 6, 7, 8. Doesn't make sense. 4 aa gaya, you have to start thinking I need the second. Clear on this? Clear? Huh? So which is the second vasopressor you use here?
Adrenaline.
Vasopressin.
Anyone else? Adrenaline, vasopressin, anyone else? So what again? Let's go back to the pathophysiology. What is the pathophysiology saying? That there is going to be vasodilatation. I have now given noradrenaline and vasoconstricted the whole thing. Okay, that means the alpha receptors are totally taken up now. Now you giving more noradrenaline is not going to help me at all because the alpha is completely maxed out. Correct? There's nothing happening on the alpha. The beta one is something that's not going to really make a big difference because it doesn't increase anything per se. So the adrenaline is kind of stomped out. The only thing you can do is use another mechanism. Another mechanism would be actually combating nitrous oxide. And the other mechanism of combating nitrous oxide will come from stimulation of V1 receptors from vasopressin. You getting the point? So there is no point of starting adrenaline. Once your noradrenaline has reached 5 ml, the next drug you start is vasopressin because vasopressin is a hormone. Okay? It will combat that mechanism which has not been combated yet. Alpha and beta are taken care by noradrenaline. We are left with we have to have a third mechanism. The other third mechanism that we have is V1 receptors, and that's why we start the patient on vasopressin. Now, what is the dose at which we will start? As I told you, vasopressin is not something you start and titrate. It is not like that at all. Vasopressin is a hormone. तुम अगर कोई hormone देते हो, तो तुम titrate नहीं करते हो. You give that hormone because there is insufficiency. So what happens in these patients of vasodilatory shock? There is relative adrenal insufficiency, relative vasopressin insufficiency. Relative vasopressin insufficiency. AVP comes down, arginine vasopressin comes down. That's why nitrous oxide increases in all of these patients. So since it's coming down, I replace that. So the approximate amount I have to replace is 0.03 units per minute. That's the production. That's the production of vasopressin. So how much you give? 0.03 units per minute. Clear? That's why we have a fixed dose. So 0.03 into 60 is 2.4 ml per hour. 6 3s are 24. So 2.4 ml is units you need to give. That is why we put 40 and start 2.4 units per minute per hour. समझ में आ रहा है? 2.4 ml per hour. Clear on this? So it's a fixed dose. Okay, it's a fixed dose. So 0.03 units per minute. Start at 2.4 ml per hour. There is no titration in this. And why is there no titration? Because it's a hormone. Hormone में कोई titration नहीं होता. Similarly, when you want to get off the vasopressin, don't start 2.4, 2.2, 2.1, 2. It doesn't work only. It's not tight. It is titration. Either you need it, or you need it very less, or you stop it. So when I'm retitrating my vasopressin, it's 2.41 and off. Getting the point? Getting the point? So if I have, so the point is, I put the whole thing together once more. Patient comes in with sepsis and septic shock. BP is less than 65. You have done an ABG that shows lactate to be on the higher side. You do the capillary refill time, it's very high. It's more than 6 seconds and things like that. You cause the urine output to be very low. It's not passed urine since the last hour or so in the history. Last 2-3 hours has been no urine output. You decide to give fluids because you've diagnosed this as septic shock because there's a history of that. But you don't waste time. In the first 15 to 20 minutes, you give with a pressure bag the first liter of fluid. Then after that, in the pressure bag, you give the next liter of fluid in the next 15-20 minutes. And the remaining amount in the 30 ml per kilogram, you give finish in the first 1 hour. In the meantime, I will send my blood cultures and give the first dose of antibiotics. In the meantime, I will send my blood cultures and the first dose of antibiotics I'll give right away. And then what do? If the BP still doesn't come and remains less than 65 at 1 hour, I will now give the patient a dose of noradrenaline. I start 850 noradrenaline. If the noradrenaline reaches 5 ml and still the BP remains lower than 65, I will probably add a vasopressin, and vasopressin I will not titrate. I will start at 2.4. Noradrenaline titrated, vasopressin I am not titrating. I am reaching 2.4 ml per hour immediately. Okay? Clear on this? Clear on this? Now, the next step in the surviving sepsis campaign guideline is, what does it say now after you have done the resuscitation? Now, the next resuscitation is completely based on dynamic fluid indices, which we did last time. Till now, we do not check for pulse PLR, passive leg raise, we do not check for pulse pressure variation, tidal volume challenge, ATCO2, which we discussed last time. We discussed all the dynamic indices of fluid responsiveness. We discussed all of them, correct? We discussed all of them. Okay. Those things now come in place after you give the first resuscitation. So after you give the first resuscitation, then comes your dynamic fluid indices. So the next drop of fluid will go only and only after you do any kind of test for fluid responsiveness, and of which the test that we want to do is dynamic fluid indices test. Okay. What are you trying to look at? You are looking at improvement in capillary refill time, you are looking at improvement in lactates, you are looking at improvement in urine output, you are looking at improvement of altered mental status. Clear? This is what you are looking at by doing all of these things. You have an endpoint to these resuscitations by doing all of these subjective things together. Clear on the subjective and some objective stuff. Clear on this? Now, if the patient receives the two doses of vasopressors, then immediately you start this patient on a steroid. Okay, immediately start the patient on the steroid. And which steroid do you want to use here? Which steroid do you want to use here?
Usually we use
Sorry?
hydrocortisone.
We use hydrocortisone. That means that is the steroid we have to use. We have to use hydrocortisone. Okay. Now hydrocortisone we are giving 50 milligrams 4 times, or you can give 200 milligrams as an infusion over 24 hours. Now why do we do hydrocortisone? What is the background behind hydrocortisone? Any idea? Now here what has happened is the adrenals have been maxed out because everything has been done. It has given so much of, now any more cortisol is not coming out. No more cortisol is coming out because what has happened is adrenals have worked so hard that it has no more juice to give out cortisol. Okay? Because you have given so much of norad, it requires so much norad, it requires so much of vasopressin. Okay? Okay, that means the adrenals are not working. You and me are maintaining our blood pressure because the adrenals are working. You're understanding? So adrenals are not working over here. Okay? So since adrenals are not working, I am giving a replacement. And that's why there is no titration on this. You understand? And the replacement for such adrenals is 200 milligrams of hydrocortisone. Now why not dexamethasone? You'll ask me why not dexamethasone? Now why? Why not dexamethasone? What are we wanting to do with hydrocortisone? We want both activities. We want mineralocorticoid as well as glucocorticoid activity. We just don't want glucocorticoid. And what happens with dexamethasone? It is mostly glucocorticoid activity. That is the first reason. Okay? So I want to have something with mineralocorticoid as well as glucocorticoid. Okay? That's the first reason. The second reason is the dexamethasone is very long acting. It is 36 hours acting. Long, its half-life is 36 hours. Okay? So it can remain in the body for a long period of time. This is the entire point. Second thing, it's got more of glucocorticoid activity. The third thing is what we know is because of its excess glucocorticoid activity, there is more immunosuppression as compared to any other any of these things. Clear? 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 Now hydrocortisone I'm going to start at 50 milligrams 4 times in a day. Clear on this till now? So how long do we continue this? How and you understand the trigger. The trigger is the moment you get the next vasopressor on. The moment you get the next vasopressor on, so you will not give hydrocortisone if you don't have the next vasopressor. You will not give hydrocortisone if the noradrenaline is coming down. You will not give hydrocortisone if the MAP is getting maintained. But if the MAP is not getting maintained, the hydrocortisone, there are two vasopressors that are there. I want to give this patient hydrocortisone. Clear? Huh? So what is the dose I'll give? 50 milligrams 4 times in a day. How long will you continue this? Yes sir, if I ask you this. How long? Why did we give it? Because the adrenals were not working,
Yeah.
correct?
Yes.
So how long will you give it?
So until the anaerobic requirement comes down,
Rubu gets off.
then gets off.
Unless the inotropic requirements gets off, I will continue the hydrocortisone. In fact, if today the inotropic has come off, tomorrow I will get off the hydrocortisone. You understand? So say today morning 9 a.m. the inotropes have moved off, vasopressors have moved off. I'll wait for the next 12 hours. At least 12 to 24 hours I'll wait, and then I'll stop the hydrocortisone. The timing you understood? Timing of starting you understood? Timing of starting is when you have 2 vasopressors.
2 vasopressors. Yeah. Second when you start.
Okay? And timing of stopping you understood? After
Stopping 12 to 24 hours.
After stop the vasopressors, wait for 12 to 24 hours, then stop your hydrocortisone. Clear? Clear on the hydrocortisone? Okay. Now, you always hear this thing, na? Hydrocortisone steroids require tapering. So, do you taper this? Do you taper this? Do you say 50 milligram 4 times, 50 milligrams 3 times, 50 times? You might have seen me doing this very often. Some patients have tapering, some have not. Why is that? So what is known is the HPA axis, the hypothalamic pituitary axis, stops producing ACTH because ACTH is required to stimulate adrenal.
Stimulate, yeah.
Hydrocortisone stimulate करने के लिए to get that adrenals working, you need ACTH coming from the top. If your ACTH stimulates, then only your steroid comes out. Now what is known is after beyond 7 days, this axis does not work.
Axis, yeah.
This axis does not work. So this axis does not work beyond 7 days. So if you are given a hydrocortisone for less than 7 days, I can do a hard stop. I can just stop it. I don't need anything. I don't need to taper it. Clear? Clear on this? Huh? But if you are going beyond 7 days, I will need to consider tapering the hydrocortisone slowly. Now when I say slowly means what does it mean? When I say slowly means what does it mean? Huh? When I say slowly it means finishing it in 3 days. It's not like prednisolone. Now you've seen prednisolone, no? How do they do it? 5 days, then another 5 days, another 5 days, another 5 days. Here is only 3 days. Why is that difference? Why is there a difference there? Why do you think there's a difference? I just now said 2 different things. I said both are steroids, prednisolone as well as hydrocortisone are steroids. Both are going to affect the HPA axis. Both are going to affect the HPA axis. But one I'm saying you stop in 3 days, and the other one I'm saying stop in slowly over a month.
Dose difference.
No, not the dose. Why do you give the prednisolone in such cases? You give the prednisolone for these patients who got COPD, right? Who got some kind of allergic reactive airway disease or something like that, where we give very high doses, 50 milligrams and 40 milligrams of prednisolone we give. But the reason you are giving is not to replace the hormone. The reason you are giving there is to reduce inflammation. The reason is to reduce inflammation. It's unlikely that you are giving it for anything else. You are giving it for reducing inflammation. Whereas here it is what? Hormone replacement. So in hormone replacement, what is going to happen? Your patient has come out of your problem. Your HPA axis will immediately trigger the adrenals to come out. You are just stopping it in 3 days time because adrenals will start working. Whereas there what is happening is I am in an inflammatory situation. Inflammation does not come out in 3 days. You are getting the point. Since the inflammation does not come out in 3 days, also the HPA axis is not probably working that well. Both the things put together, we say let's taper it because inflammation has to be also taken care of. Inflammation takes 6 weeks. You are getting the point? And that's why we do a slow taper when we give prednisolone, because we are giving prednisolone for not of hormone replacement. We are giving prednisolone because we want to get the inflammation down. There are 2 different pathophysiologies when you look at sepsis, septic shock versus inflammatory conditions like reactive airway diseases. समझ में आ रहा है? So today what we have done now is only the first 1 hour. First 1 hour of septic shock. How do you manage the first 1 hour? Clear? Any doubts on this first 1 hour? This is only the sepsis first 1 hour bundle. Okay.